Okay, so the NCE and abnormal psychology. Let's understand the role of the DSM-5-TR. So the DSM-5 is the primary tool for understanding and diagnosing mental disorders. While abnormal psychology is not explicitly tested content area based on the NBCC content outline, the knowledge is indirectly assessed. And so you might find NCE questions that incorporate symptom recognition, differential diagnosis, or application of theoretical knowledge to clinical scenarios. And so it's important that you are familiar with the DSM-5 because this is going to increase your ability to answer NCE questions accurately. Now, I know that may feel really overwhelming to some people because the DSM-5 is huge, but I think that the approach that we're going to take will help you to feel a little bit more, to make it feel a little bit more manageable. Okay. So you can expect that you're not going to have memorized DSM criteria. Okay. But you are going to need to be able to recognize abnormal behavior patterns, have a basic understanding of the categories of diagnosis, and again, be able to differentiate between different disorders. So, for example, there may be questions related to like which diagnosis fits the following symptoms, or identify the disorder based on these case details. Excuse me, we're going to go through an example of that here in just a minute. Okay, so the basic assumption is that the exam is going to assume that you have an understanding of human growth and development, which of course is another NCE content area. And that basic understanding supports your ability to identify these developmental milestones as well as deviations from that. You need to be able to recognize patterns of normal and abnormal behavior. Okay, and that's what this knowledge is going to be able to help you to do, is to integrate knowledge of the DSM symptomatology to be able to discern abnormal psychological patterns in exam scenarios. Okay, are we clear so far? Stop me if I'm going too fast. Andre, this is being recorded and it'll be uploaded to the Tutoring Archives lesson as well as the Chapter 2 Subject Series if you want to replay it there. Okay.
Will we get the slides, Josh?
Yeah, in the community portal, in the discussion section, I posted the PDF of that, and I'll also have that attached to the lesson in the Tutoring Archives and the Subject Series. Okay,
Thank you.
perfect. Okay, so focus areas. Understanding key diagnostic criteria for common disorders, for example, major depressive disorder, generalized anxiety disorder, PTSD, but also, again, recognizing symptom patterns rather than memorizing numerical criteria. Don't focus on 7 out of 10, things like that. That's not going to be a good use of your time. Cross-content connections. So how does knowledge of child development inform the recognition of disorders like the autism spectrum disorder? This is going to be an important thing to understand because if we know what normal human growth development looks like, we'll be able to identify deviations from that. And then again, how do stress and trauma impact behavior across the lifespan? So there's a lot of ways that the DSM-5 intersects with other knowledge that you're going to be studying and preparing for. So here's an example case scenario. So a 15-year-old presents with irritability, lack of interest in previously enjoyed activities, and difficulty concentrating over the past 2 months. Based on this information, which disorder might you suspect? Generalized anxiety disorder, major depressive disorder, attention deficit hyperactivity disorder, or oppositional defiant disorder. What do y'all think?
Major depressive disorder.
Major depressive disorder. Okay, that's what a lot of people in the chat are saying as well.
I can say C.
You say C, okay.
B or C?
B or C. Yeah. So this is a really good example of how we have to take symptoms that are presented in a scenario and differentiate between different options in order to choose the very best one. Okay, so let's break it down a little bit more. This one is actually major depressive disorder. Okay, so let's look at each of the symptoms so we can understand how we would need to understand the symptoms to be able to connect it with major depressive disorder. So the scenario describes a 15-year-old with the following symptoms: irritability. So in children and adolescents, irritability can replace the depressed mood criterion often seen with adults in major depressive disorder. Okay, so that's how that might show up in children, is with this irritability. Lacking interest in previously enjoyed activities. This aligns with the DSM-5 criterion for anhedonia, which is a hallmark of major depressive disorder. Difficulty concentrating, so cognitive impairments such as difficulty concentrating. These are common symptoms of MDD. And then duration, the symptoms have persisted for over 2 months, exceeding the 2-week minimum duration required for an MDD diagnosis. So we could look at all of those symptoms and attach it to major depressive disorder. So why not the other options? Okay. For generalized anxiety disorder, while difficulty concentrating can occur in this, the scenario lacks hallmark symptoms like excessive worry, or specifically physical symptoms like muscle tension, restlessness, and things like that. So we could rule out generalized anxiety disorder. That's for ADHD. Difficulty concentrating is one of those symptoms, but ADHD typically presents with persistent pattern of inattention, hyperactivity, impulsivity, not mood-related symptoms like irritability and anhedonia. So we would want to rule out ADHD because of those mood-related symptoms that were described in the scenario. And then oppositional defiant disorder. So irritability is a feature of this, but ODD involves a consistent pattern of defiance, argumentativeness, vindictiveness, and that's not described in the scenario. So can you see how we'd need to understand kind of the hallmark symptoms in each of these disorders in order to be able to either choose the best one or to rule them out? But we're not having to identify, 5 out of 7. Okay. Does that make sense? That's the strategy for studying the DSM-5, is to generally understand what goes with each of these diagnoses so that we can zero in on the right one and rule out the wrong ones. Questions? Okay. So again, do not attempt to memorize exhaustive diagnostic criteria. Hopefully that's a relief to some of you that you don't have to do that. Okay. Do focus on understanding core symptoms of common disorders, recognizing symptom clusters and their functional impact. A symptom cluster might be all of the different, like, depressive disorders. Okay. Those all kind of go together. Relating diagnostic criteria to developmental and cultural contexts. Okay, as we need to make sure that we're understanding that some of these diagnoses only go with certain ages and not with others. And then there's other contexts that are happening culturally that also impact individuals, whether the symptoms are actually diagnosable or not. So the tip is just to practice identifying hallmark symptoms in sample scenarios. Okay. So let's look at how the DSM is approaching, the DSM-5 specifically is approaching diagnosing mental disorders. Okay. DSM-5 came about in 2013, and with it, a revised content structure was created to bridge traditional diagnostic categories with modern research. Earlier DSM versions treated diagnoses as categorically separate, but with the research that's been done in the last 10 or 15 years, the DSM-5 recognizes that mental disorders are heterogeneous. What does that mean, heterogeneous? Any ideas?
Different
Different?
groups.
Yeah, they're different, they're varied. We can't specifically label them all alike. Homogeneous would be all alike. Heterogeneous means all different. So they exist on a spectrum that's influenced by genetic, environmental, and social factors. And so it's not so simple to just categorize this goes with this and this goes with this. There's a lot of varied reasons why somebody might have a specific mental disorder. And so instead, it's been organized according to lifespan. So disorders commonly diagnosed in early childhood, for example, autism spectrum disorder, those appear at the beginning of the manual, and then disorders that are more prevalent later in life, like neurocognitive disorders, appear towards the end. Okay. And again, the rationale is that it aligns with developmental trajectories, and this improves the clinical usability of the actual DSM-5. Okay. So I was asked earlier today about changes from the DSM-5 to the DSM-5-TR. I don't know that you are going to be tested specifically on what's different, but it's important to know some of the things that are included in the DSM-5-TR. Okay, so you're not going to have to know why one is different from the other, but the questions that you're asked are going to focus solely on the most current DSM-5-TR diagnostic criteria, which really hasn't changed much. Historical comparisons or debates about changes are irrelevant, right? There's a lot of chapter content in the DSM-5 related to this. I don't recommend you study from the DSM-5, right? I know some people will pull this out in order to study. If you do anything, I would just suggest looking at the outlines at the beginning of the chapter to see how they're grouped and clustered together. But again, because we're not focusing exclusively on the diagnostic criteria, there's lots of other ways of getting summaries of the content than looking at the specific DSM-5. Okay. Beverly?
Yes. When you said look at the beginning of the chapter of the DSM-5 or the beginning of the chapter of the study manual?
Well, I meant the beginning of the DSM-5 as a whole. So at the
Okay.
table of contents.
Okay. I
Okay.
just wondered which one.
Yeah. Now, I do recommend that you don't skip over the condensed outline at the beginning of my study manual. When you're going through and skimming, that condensed outline is really important to go over as well. And we'll cover that at the very end of our session today when I look at how to skim. Okay. So don't hear me saying skip over anything in the NCE exam prep study manual. Okay. So back to the DSM-5-TR. One of the things that the TR differs from the DSM-5 without the TR is updated cultural content. And so in section 3, this is one of the areas that that was updated. So it's expanded to address broader cultural dimensions of mental health, and it provides tools for understanding cultural influences on symptom expression and diagnosis. There are some diagnoses that exist only in certain cultures, which I think is really pretty fascinating. Some of you may not have ever heard of any of these unless you're from these cultures, but these specific syndromes, I guess diagnoses might not be the right word, but syndromes are referenced in that chapter. I don't think you're going to be tested on them, but again, this is one of the things that was updated in the TR. So for example, and forgive me if you're from one of these cultures and I'm mispronouncing it, you've probably been saying it wrong your whole life. I'm kidding. That's a joke. Y'all Cap from Cambodia, the DOT syndrome in South Asia. So again, you may not have had any reason to know about these unless you're from those cultures. So you can expect questions that test your ability to identify culturally appropriate diagnoses and understand the role of culture in mental health. Obviously, that's a huge component of the NCE's understanding culture. Okay. Other updates to the DSM-5-TR. This is actually one of the new diagnoses is prolonged grief disorder. characterized by intense disabling grief that persists beyond expected cultural norms. And then there's some changes in terminology. For example, gender dysphoria, updated for greater clarity and inclusivity. Intellectual disability terminology aligns more closely with WHO's ICD-11. Don't worry about knowing the ICD codes or anything like that. And then key diagnostic groupings. So, for example, with neurodevelopmental disorders, autism spectrum disorder continues to encompass prior subtypes, so that's not changed. And then with depressive disorders, there's revised criteria emphasizing symptom duration and functional impairment. But because you're not needing to memorize the specific diagnostic criteria, it's just general information about how the TR has been updated. Back to the tip is to focus on the hallmark symptoms of the new or updated disorders, but not the diagnostic criteria. So, with the developmental focus that came about with the DSM-5, disorders remain grouped by developmental stages, but there's more detailed developmental considerations included, and they've expanded on the content. You know, there's clarifications in childhood versus adult presentations of it. And so the implications for the NCE are that you need to be able to recognize how symptom varies across the lifespan. Okay. How is this going to look different for a teenager than a retired person, for example? Be prepared to link developmental milestones with potential disorders and case scenarios. Okay. Questions before we move on to the next section? I know I'm breezing through the material because there's a lot of questions that people typically have at the end. Okay. We're just understanding the DSM-5, what to expect, how to study it. All right, let's look at the definition of a mental disorder presented by the DSM-5. A mental disorder is a clinically significant behavioral or psychological symptom or pattern that occurs in an individual and is associated with distress, disability, or increased risk of suffering or harm. Okay, so let's unpack each of these. When we're talking about distress, we're talking about emotional pain, such as severe anxiety, sadness, or fear. For example, a person experiencing persistent, overwhelming sadness and hopelessness, which is characteristic of major depressive disorder. When we talk about a disability, we're talking about impaired ability to function in daily life, such as difficulty maintaining employment or personal relationships. So, for example, social anxiety disorder causes avoidance of social settings, leading to isolation and workplace difficulties. Increased risk of suffering or harm would include risk of self-injury, suicidal ideation, or harm to others. So, for example, a person with borderline personality disorder engaging in self-harming behaviors during emotional distress. Okay, so mental disorders go beyond temporary reactions to life stressors. They involve persistent and significant disruptions to mental health or functioning. Questions? A mental disorder is not an expected response to a common stressor. So normal grief, such as sadness after the death of a loved one, is not a mental disorder unless it significantly impairs functioning or persists beyond cultural expectations. Prolonged grief disorder. Okay. What do you think we mean, or does anybody have an example of persisting beyond cultural expectations? What might we be talking about there? Any ideas?
Well, if I had to guess,
Mhm.
I'm thinking some cultures, it's acceptable if you grieve a longer period of time, whether that is a year or 2 years.
Sure. Yeah.
And then some cultures believe, you put the person in the grave or cremate them or whatever, and you go on with your life. So that just would be my best guess.
Yeah, no, I think that's a great guess. Yeah. There's some cultures where it would be normal for like a widow or a widower to be in isolation for a long period of time, right? If it's culturally normal or expected, then we're not gonna put it in a category of a mental illness. Okay. Same with a culturally sanctioned behavior. So rituals and practices specific to cultural or religious traditions, such as fasting during Ramadan or shamanic ceremonies, are not classified as mental disorders. Does that make sense? What are some other examples of culturally sanctioned behaviors that we would not call mental disorders? I don't, sorry, go ahead.
I was saying, don't know.
Yeah, so
Like, I think like spirituality, when people say that they hear
yes,
and they see visions, people can think it's hallucination or
yeah.
things like that. But for that person, because it's a religious person, it may not be really mental
That's
disorder.
yeah, that's a perfect example that I was thinking of. I live in Central Texas, and so there are a lot of like believing, Bible believing people who would say, "Oh yeah, God told me this," and we're not going to question their sanity because that goes along with a religious outlook that they have. It's common to hear people in that specific culture, talk like that, and so again, that is not a mental disorder. We're not going to say, okay, you're hearing voices, let's check you into a hospital. Okay. And then mental disorder is not a violation of social norms alone. So behaviors that defy societal expectations, such as political dissent or nonconformity in dress, do not qualify as mental disorders unless they cause significant distress or impairment. That's why we covered that on this previous slide. It's got to have significant distress in order to be considered a mental disorder. So just because somebody is non-conforming in how they live their life does not automatically mean that they have a mental disorder. Okay. So again, to meet the DSM-5 criteria, a disorder must result in significant impairment in social, occupational, or other important areas of functioning beyond what is culturally or socially expected. Clear? Give me a thumbs up if it's making sense.
Clear.
Awesome. Okay. So here's how you might see some of this showing up in NCE questions. Okay. Recognition of distress or disability. So you might find some case scenarios often present individuals experiencing emotional distress, like persistent anxiety, for example, or impaired functioning, like the inability to maintain a job. So your task on these kinds of questions is to identify whether the symptoms meet the threshold for a mental disorder based on DSM-5 criteria. Okay. Like in our previous scenario, when it said 2 months, if it had said 2 days, that would not have met the threshold for a major depressive disorder because 2 days isn't enough. Okay. Secondly, differentiating between cultural norms and clinically significant behavior. So, for example, distinguishing between culturally accepted mourning practices, as we talked about, and symptoms of major depressive disorder. So, pay attention to whether behaviors are causing distress or impairment within the individual's cultural context. You're not going to have to read anything into the question. So we're not going to assume anything culturally that's not specifically stated in the question. Right? We don't have to guess what it's meaning. It's going to give us all of the information that it needs us to know. Does that make sense? And then third, identifying functional impairments. So focus on whether the individual's symptoms interfere with daily life, such as maintaining relationships, holding a job, or engaging in self-care. A case involving a child with persistent inattention and hyperactivity might require you to assess whether the symptoms are impairing academic or social functioning. Okay. How is it impacting day-to-day life? If it's not impacting day-to-day life, it may not be a mental disorder that's diagnosable. Side note, this is why I'm really thankful that we have adjustment disorder in there, because a lot of people want to bill insurance and they don't fit a criteria, but adjustment disorder can be kind of a catch-all because there's lots of adjustments that we could say are impacting their day-to-day life. Okay. Questions are designed to assess your ability to apply DSM-5 criteria to real-life scenarios, emphasizing distress, impairment, and cultural context. All right. So this is not the kind of question that you could see on the NCE, but it might test your knowledge here. So a 30-year-old client reports intense fear of social situations, leading to avoidance of work events and decreased social contact. Which diagnostic feature is central to identifying a mental disorder in this case? Intense fear of social situations, decreased social contact, impairment in occupational functioning, or avoidance behaviors. Okay. A lot of differing answers in the chat, which is good because that lets me know we need to spend a little bit of time on this. What is the question actually asking?
Well, I don't know what it's actually asking, but I recall you just said everything depends on impairment. It may be
Yeah.
something happening, but it's not impairing their ability to go to work, to have relationships. But in this case, they are avoiding work events. They're avoiding. So to me, that is impairment.
It looked like it's asking what's the feature?
Right.
What's the diagnostic feature and central to identify a mental disorder?
Good. So which one of these answers is a diagnostic feature? Is intense fear of social situations a diagnostic feature? Or would that be considered a symptom?
Symptom.
That'd be a
I
symptom.
would say symptoms.
Yeah. Decreased social contact. Is that a symptom or a diagnostic feature?
Symptom.
Symptom.
Avoidance behaviors. Is that a diagnostic feature or a symptom?
Symptom.
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 Right. So this is asking about how are we determining whether something is a mental disorder, not what are the things that we're noticing. Does that make sense? So it's kind of understanding how are we arriving at whether it's a mental disorder. Well, we're looking at the features. Is there impairment? Is there distress? Is there disability? That's what we're looking for.
That is so
Also-
funny because I gave you the answer, but in the chat I wrote the wrong answer.
Yeah. And that's okay. You know, sometimes you'll arrive at the right answer by the wrong reason. Take it, right? That's no problem. Okay.